things. So first is that it's very hard to bring nurses out, in and out the setting. But I thought what is important is that there must be a good communication between nurses from different settings. So I have community nurses in the community and then I have nurses in the ward. I have also nurses in the SOC, the special education clinic. Currently we are still building but the final picture I hope to see is the ward has got our own nurse specialist. If I'm a patient with uncontrolled diabetic, I come into the hospital. After I have been treated, there's no way to treat you to clear or to make sure that you're back to stable blood sugar, right? I can discharge you, but I may now hand over the case to my SOC nurse specialist who is looking after the DM patient. All right. So once she take over, she will continue to she take over the care. Patient go to the community, and if we think that the patient do not require a community nurse follow up, then the SOC nurse will now take over to make sure that there is a link as such. And of course, I think transition care doesn't mean that we always look after patient, but it's how do I transit patient to a care or to someone whom I trusted that will carry on with the work. It can be sometimes a lay person. For example, if I'm a DM patient, eat nonsense, right? Ultimately, when I move the patient out, I may have to link up with the community players where they can actually coach the patients, But if I think patients still need follow-up by our medical team or nursing team, we may then refer to our community nurses to follow through. All right, and then when they go back to the SOC, that's where the SOC start link up with the patient. So, but I think transition care cannot be too rigid, thinking that we have to handhold patient all the way. But it's the ability to have being resourceful to really know who I can hand over the care to. And to me, transition care doesn't just happen from ward to out to community, but it is about ICU down to inpatient ward, to the general ward setting and so forth, so on and so forth. For example, OT after operation, transit patient to inpatient. I think everybody must always remember one thing, that you do your best at where you are. If you have done your best, you want to make sure the good work continue. So you must know next, from operating theatre, if I send a patient out to the general ward, I will expect the OT people don't just hand over, but they have to make sure that the care that they hand over to, or the person that they hand over to, does have the capability. So we do have a model that we are working on, is by asking some of my senior OT nurses to actually come out post-operatively to go to the ward and look up and at least communicate with my general ward nurses, especially when the surgery is complex. You know that your patient is sick enough, you must be responsible enough to receive patient over there, send over patient to someone who can receive the case well. It's the same thing for ICU. So ICU, they came out with their own outreach. If patient from ICU come out to the general ward, they say for complex, for certain cases that they are not very comfortable, they will follow through. So to me, this is how nurses should work together. You segregate, yet you know when you need to come together and make sure that the care is well connected. I think that is very, very key.